First presentation for today's grand round. So we have CN, who is a 21-year-old female Uganda by tribe, and she's a practicing Catholic from Mutungu in Kampala, and she was being taken care of by the mother. She's single and a second-year undergraduate student at Deji University doing quantitative survey. She was referred to Uganda Art Institute from Deji University Clinic on the 16th of this month. So the main concerning issues were right-sided body weakness, which was for 1 week, headache for 2 days, and vomiting blood for 1 day. As a background, she's a patient known to have rheumatic heart disease, diagnosed echographically or echocardiographically on October 2012, which showed, the echo showed features of mitral regurg, severe mitral regurg, mild aortic regurg, and severe tricuspid regurgitation as well, with features of moderate pulmonary hypertension and mild pericardial effusion. The ejection fraction at that point was 70%. But later on in 2013, she deteriorated with a decline in ejection fraction to 61. The following year, in October 2014, she had a mitral valve replacement from the Salam Center in Khartoum, North Sudan. Otherwise, she has been on some routine regular medications, including monthly benzathine penicillin and warfarin, of which she was alternating between 5 and 2.5 milligrams once a day. And she reported a good adherence. But otherwise, she has been irregular at the Uganda Art Institute OPD because of the conflict between review dates and schedules at the university. And she has also been having issues with monitoring INR because of financial issues. But what we also have to know about the patient is that the patient doesn't eat meat, so she's mainly vegetarian. So just a recap of the presenting issues, which has been right-sided body weakness, headache, and vomiting of blood. So it all started 1 week prior to admission, that is on the Independence Day. Just after Independence Day, when she developed sudden onset of right-sided body weakness, mainly on the right upper limb, but also right lower limb. But with right upper limb being more than what? The right lower limb. And she was unable to write, and there was an associated visual disturbance. So she also had problems with reading difficulties, and coupled to inability to write, she was not able to do her mid-semester exams. However, she did not report any history of headaches, convulsion, neck stiffness, or fevers. She did not also report history of loss of consciousness, and there was no preceding palpitations or unilateral lower limb swelling, and she was able to converse normally with family members and colleagues at school. So 2 days prior to admission, she developed a headache, which she described as the worst headache of her life, and gave a severity of 10 over 10. It was generalized, slightly improved with paracetamol. And she also noticed worsening of visual symptoms, and she progressively became weak and also dizzy. However, she still did not report convulsions or neck stiffness or fevers, and there was no history of vomiting. She did not lose consciousness, just like in the onset of the disease, and she was able still to converse normally. On the day of admission, she vomited fresh blood, 2 episodes, one at Ndeje and the other at the Art Institute, each about 150 mils. She also reported sneezing blood and coughing up blood, and also frank blood in urine. She also noted bleeding under the skin of the left arm. And there was also a positive history of generalized body weakness. However, she did not report blood in stool or altered stool. There was no alteration in bowel habits, and she also did not report gum bleeding after brushing that morning, and there was no joint swellings. A review of other system was only significant for a mild on and off coughs, but also her heart was still clicking. In past medical history, patient was admitted on the 27th of September, was hospitalized for a total of 4 days, and the issues at that point in time was an elevation in the INR, which was 6.81, with also severe anemia. There was no features of acute heart failure, and the intervention at that point in time was blood transfusion with 2 units of packed red blood cells, and warfarin was withheld for 3 days until INR was therapeutic, and she was allowed home on day 4. Otherwise, she doesn't have any other chronic medical conditions. So in summary, I'm presenting a 21-year-old female, non-patient of rheumatic heart disease who has had mitral valve replacement with irregular INR OPT reviews, who presented with left-sided body weakness associated with headache and blurring of vision and bleeding from multiple sides. There was no history of fever, convulsion, or loss of consciousness. So on the day of admission, she had a BP of 115/70 and a pulse rate. There was a bradycardia of 56, and she was breathing ambient air with SpO2 of 99%. And general examination revealed a sick-looking young lady who was drowsy, febrile on touch, with mild pallor of the mucous membrane. CVS was only significant for an audible clicks, which on auscultation we also noted a click. CNS, she was fully conscious, but we noted a right facial nerve palsy, and she did not have signs of meningeal irritation. Sensory and motor modality were mainly normal, except for the left upper limb. Okay, the left upper limb and left lower limb powers were 5/5, but the right upper limb and the right lower limb had a power of 3 out of 5. The reflexes, tone, muscle bulk, sensation, and proprioception, and the rest were normal. So our problem list on the day of admission was probably a warfarin toxicity presenting with extracranial as well as possible intracranial bleed. And then there was a bradycardia. We are not sure of what could be causing it at this point in time. Then anemia, we're thinking probably a bleed or a prolongation of the previous admission. Then the quick labs at that point revealed that we had an INR of 9 and HB of 9.5 with a MCV of 65. Potassium was 4.2 and other electrolytes were within normal limits. She had a urea of 2.0 and creatinine of 0.89. So at that point in time, we stopped the warfarin and gave her 10K OD for 2 days. Blood transfusion was not given to her. And then we did a bedside ECG that showed sinus bradycardia, which was consistent with the physical findings. She was started on IV fluids. 3 days on treatment at the Heart Institute, there was no visible bleeds. She received vitamin K as prescribed, and her INR dropped from over 9 to 1.23, and our main issues at that point in time was severe headache, but otherwise the GCS was still 15 out of 15, and our vitals were stable. CT showed massive parieto-occipital bleed with vasogenic edema. Yeah, but as well as effacement of the what? Of the sulci, mainly on the right side, and some mediastinal shift. So, yeah, so our plan at that point in time was to de-escalate, because she was started on clexane, 80 milligrams OD, when the INR was 1.23. We de-escalated the clexane to 40 milligrams OD and added sodium valproate plus paracetamol. And then we requested for the neurosurgical review, of which the neurosurgeons came, and we agreed on a diagnosis of acute intracerebral bleed in a patient who had mitral valve replacement due to supratherapeutic INR. And the plan at that point in time was to manage the patient conservatively with monitor, which was given at the dose of 20 milligrams BD for 2 days, and also started on seizure prophylaxis with phenytoin and also tranexamic acid, paracetamol, and kepriaxone. So 5 days later on, the patient still had persistent headache, but the severity improved to 6/10. But the right-sided weakness persisted with visual disturbance, and the vitals were still stable. The heart rate improved to 85. So our plan was to obtain INR for that day, and then to restart coagulation probably on day 6, and monitor for 24 hours, and pain management as well with morphine. So today, she received a dose of monitor this morning, but she still reports headache of about 7/10. Right-sided weakness and the visual disturbances are still persistent. Otherwise, she's fully conscious, stable vitals, and GCS of 15/15. So we still plan to have the second dose of monitor given in the evening, and possible recommencement of what? Of warfarin. So our final diagnosis for this patient is that we have a 21-year-old female with rheumatic heart disease, already with mitral valve replacement, presenting with supratherapeutic INR due to irregular INR monitoring with intra and extracranial hemorrhage, which is a major hemorrhage. Thank you. I think probably we can get the questions after Dr. Khalid's presentation. Okay, you can ask the question.